Thank you for this opportunity. And we've got a beautiful overview from Dr. Prabhakaran and then an insight into breaking research in EKG. I'm going to give you a quick practical example of a model that we've been using for several years now that will give you insight into how this can be used. And in terms of disclosure, what I'm going to show you is a process that combines approved testing modalities and medications, but the integration of utilizing AI to drive this sort of prevention treatment has not been subjected yet to RCTs. However, one large randomized trial is underway as well as one large registry. Just for background, for thousands of years, we've practiced intuitive medicine. In fact, the Yellow Emperor's canon from about the 4th century BC, perhaps the first textbook ever published. So for thousands of years, we practiced intuitive medicine. We pivoted in the late 20th century to population-based medicine or evidence-based medicine, first mentioned in the literature in the 20th century, actually midway, almost 2/3 of the way through. And my point is that I think we're very rapidly pivoting to the next move. So thousands of years, and then a half a century, and now pivoting to the next step. Many of you are aware that the Lancet Commission reported in April 2025 on rethinking coronary artery disease. And this is important background because the conclusion was that the focus of management of coronary disease needs to pivot away from the late stages of disease, which are manifest by ischemia and eventual infarction, and migrate toward earlier detection of disease. Now, there's a lot of data on this, and if we go back to 2008, our colleague Dr. Narula led a group that demonstrated that positive remodeling coronary segments and low attenuation plaques on CT were predicted higher risk of acute coronary syndrome. And a second paper, a different group, but again led by Dr. Narula some years later, again looked at high-risk plaque, but also importantly showed that plaque progression is an independent predictor of coronary events. The well-known Scott-Hart trial has pointed out that low attenuation non-calcified plaque predicts myocardial infarction, and those authors concluded that these findings really challenge the standard approach that we've utilized for years, the perception of the superiority of classic risk factors and detection of ischemia, and that we need to now, with the use of better imaging and artificial intelligence, as I'll show you, migrate to earlier detection of disease. And finally, just published a couple of months ago, this comparison of the prediction of event rates based on stenosis versus bulk of plaque atheroma shows the superiority of the latter over a long period of time. Now that's in contrast to what most of us were taught in medical school, where we were dependent upon the degree of stenosis predicting event rates. And we are now understanding scientifically that that's not so much the case. And then finally, does it make a difference? And the answer again from the Scott-Hart trial was yes, it does make a difference. Because if you detect disease earlier, as was shown in Scott-Hart from 2018, you actually can institute therapy with preclinical disease impacting event rates and MACE over a 5-year period of time. So this detection of plaque and subsequent intervention, particularly in preclinical plaque, can make a big difference. And here's the reason why. Many of you may know that in the 1980s, a well-known pathologist from the University of Chicago, Dr. Glagov, started recognizing the concept that preclinical plaque grows outward rather than inward. Very important, because if one thinks about stress testing, we're looking for ischemia, which is dependent upon narrowing in the lumen of the artery. If we think about coronary angiograms and the thousands that I've done over decades, we're looking at a luminogram. But if one looks at these diagrams that you see here, it takes a huge amount of plaque, and perhaps it's estimated about 40% plaque volume before encroachment on the lumen begins. So it's only more recently that imaging such as CT allows us to look outside the lumen and allows us to detect earlier. Now, how is that helpful? In addition to looking at the plaque burden by utilizing very simply Hounsfield units, we can now begin to also distinguish the different types of plaque, and we know there's a gradation in risk. Those with low attenuation plaque are much more likely to rupture or erode and cause acute coronary events, while on the other hand, calcified plaques with high Hounsfield units are a much lower risk, and there's abundant literature that confirms that. So AI can help us in terms of quantitation, but also characterization. Now, this group doesn't have to be reminded that the advantage of a coronary CT is that we literally can go all the way down the coronary artery. We can look at the wall utilizing color coding. In this case, we can characterize the type of plaque as well as the magnitude of the plaque, something that we really couldn't do before. Now, our other alternative to doing this, of course, is an invasive coronary angiogram with IVUS looking at the wall, but not practical to look at the entire coronary tree as we can do non-invasively with CT. So if one subjects this data set to artificial intelligence, the output looks something like this. So there's again reorganization of the data set that allows the ability to quantitate numerically the amount of plaque in the entire coronary tree, or by segments, or by arteries, but also to characterize the amount and type of plaque in each of these segments as well. That numerical value becomes particularly important if one's going to track. And I pointed out to you before that progression of plaque is an independent predictor of events, independent of the plaque volume. So that ability to track numerically becomes important. Now, can you do that without AI? And the answer is yes. And the estimates are it takes a level 3 CT reader about 9 hours per case to be able to quantitate that. It's just not practical. AI does it for us in a matter of several minutes. So with that as prelude, let me tell you a bit about our program. We've been running a program that's based on our health system employees. So it's a combination research trial, but also a prevention trial free to our enrollees. They have to be at least age 45 with one risk factor. It's voluntary, standard exclusions, and a standard coronary CTA that is then exposed to artificial intelligence evaluation, reviewed by us, and then there's a management plan that's put in place. The primary goal is reduction of cardiac events in our employees, improved health. Our secondary goals are cost reduction, and I'll talk about that in a moment, and then the data sets on efficacy. The workflow looks like this, beginning with identification, then education, implementation, management, and tracking with the hope of preventing disease downstream. So the identification of plaque looks like this. I showed you this a moment ago. An individual undergoes coronary CT angiography. We quantitate the amount of plaque and the type of plaque, and that allows us then to categorize it. This rough categorization has been published in the past and has been subjected to some research, although again, this is fairly early and this may be modified over time. This is the current staging that we use. And there is data that shows that there's prognostic value, substantial prognostic value. And I might point out, if you look at that top line, that those with no plaque whatsoever have a zero cardiac event rate at 10 years. And progressively, as one gets to stage 3, substantial event rates over 10 years. Now, this is over and above coronary calcium scoring. This is actually looking at the total plaque. So our second step in this is education. So we provide information to the clinicians, as you might imagine, particularly In primary care, many of the clinicians are not well familiar with this. Our cardiologists are becoming increasingly familiar. So we provide reports to the clinicians explaining what their patient has. We do the same thing with our patients, only providing that at a much lower level so they can begin to appreciate. Now, as all of you can imagine, when we educate these patients and actually show them their own images with AI-enhanced characterization of their plaque, the impetus for them complying with lifestyle modification or medications, if needed, is pretty high. So most of these people do follow through. So we manage this. It's a busy slide, but it's just to give you an idea that we utilize a management algorithm that was developed by a panel of experts. Again, this same algorithm is being subjected to a randomized controlled trial that's underway as we speak, but we're using this currently. Now, the tracking is really fascinating because over time, we literally are repeating these studies. If in our population, for purposes of our study, if we see no plaque, we actually rescan at 4 years. If there's still no plaque, then that individual is taken out of the program. On the other end of the scale, if there's severe plaque, we institute aggressive measures to try and retard plaque progression, and we rescan at 1 year. Now, our first 400 looked like this. Interestingly enough, and somewhat surprising, and with a higher number than the Miami Heart Study, 80% had stage 1 plaque. A lot of this was very, very minor plaque. Hard to know what the clinical significance of that is. But importantly, 3%, now remember, these are asymptomatic employees. 3% of these had stage 3 plaque. That's a lot of plaque. And a substantial percentage, 4%, also had stage 2 plaque. Now, when we broke that data set down, it was very interesting that 40% of those with stage 1 plaque had calcified plaque. So most of the stage 1 plaque is non-calcified in this population study. Also importantly, those with a standard risk score of less than 5%, 17% of those people with a risk score of less than, of those with stage 3 plaque, advanced plaque, would not have been identified by standard risk scoring. We have an abstract that's been submitted for ACC currently looking at this compared to the PREVENT score that is under embargo currently. When we extend that out to the next 1,000 or so patients, it looks very similar. These people were at slightly lower risk than our first phase, but again, most of the people have some degree of plaque. The majority of that is very minor, and I think it's that area that you see in green that will be the most interesting over time because that's the area that we know the least about. Now, those stage 3, though, are the ones that concern us the most. If we look at just stage 2 and 3 on rescans, and this is a very small data set, this is just starting, you see that when we looked at that, there were no regressions. These were people who were rescanned at either 1 year or 2 years. Some of those stabilized and some progressed, but of those that progressed, the vast majority progressed with calcified plaque. So conversion of higher risk plaque to lower risk plaque. So while technically in terms of progression, their atheromatous volume increased, most of that was calcified plaque. So probably reducing risk. That's our hope in the long term. This is an abstract that was published last year. This was the return on investment, ROI in English, return on investment for our program, showing that we actually begin to appreciate a return on investment at several years because of the investment in identifying early plaque, reducing disease, and in a closed health system, reducing absenteeism from work, use of extra funds to support those people, it begins to pay for itself and actually be profitable to the health system. Now, part of that is because most of our clinical studies, of course, look at major adverse cardiac events, but that sometimes will discount the personal and institutional costs of soft events like emergency department visits, unneeded testing, lost days of work, workers' compensation, and the like. And that's what we're looking at. We're looking at that entire data set. So very quickly, just a couple of quick examples to give you a snapshot. And these are actual examples. The first is a 59-year-old male that had a CT in January of 23 that showed stage 2 plaque with diffuse mild stenosis. The baseline LDL was substantially elevated with shared decision making. This individual declined medication and went with lifestyle modification and did reduce the LDL substantially, but still higher than we would like for our cut points. Preferred to continue lifestyle, and the repeat scan 2 years later showed a progression to stage 3. And this is numerically what it looks like. So the initial total plaque volume was 346, and it increased, it doubled to 746. And that was both non-calcified and calcified plaque. So this is very helpful with this individual because we can sit down and show him exactly what's going on and intensify therapy to try and prevent event rates. The second is a sort of scary case, a 55-year-old female, asymptomatic, again, an elevated LDL level, but when one does a standard risk scoring, like most of us do in our clinics, the risk is borderline. Now, importantly, this person had had a coronary calcium score of 0 on a screening CT of the heart, so typically, at least in our practices, we would not intervene. And yet, this particular individual had focal narrowing in one area of the mid-LAD. So although the total plaque burden was not high, it was all localized to this one particular segment. So this enabled us to aggressively manage this individual to try and prevent events. So quick summary, I mentioned to you that I think we are in the midst of what I feel is a very exciting time for us as cardiovascular specialists, where we're rapidly evolving after eons of intuitive medicine and less than 50 years perhaps of evidence-based medicine. We're migrating now rapidly to the opportunity to individualize therapy, and in this case, to base interventions, particularly medication interventions, on identification of disease rather than statistical risk. And so yesterday we were treating only the symptomatic patients that came in with acute events. Today, by and large, we treat those symptomatics, but we also use statistical risk markers for prevention, and we screen for ischemia. But as Glagov showed, that's late disease. That's not early disease. So I would submit to you that we now have the opportunity to detect, treat, and perhaps prevent events as we move forward. So just to paraphrase one of my colleagues, Dr. Ami Bhatt, perhaps it's not artificial intelligence, but collaborative intelligence that will help move us forward going forward. So thank you very much for your attention.